Foundation give me opportunity to go to the United States for 6 months in 2024, and also some of the experience in the Teishinkai Hospital. So these are the institutions that I have been most of my career. My hospital in Guadalajara, that is the Guadalajara Civil Hospital, one of the oldest hospital in whole Latin America. The Arkansas Neuroscience Institute, that is a very beautiful and complete place to do neurosurgical treatment and neurosurgical study. Of course, the Stanford Hospital, there is really a high-tech neo hospital, and the Teishinkai Hospital in Sapporo, Japan. So I want to share to you this picture that was taken December 6, 2014. More than 10 years ago, 12 years ago, when I get the book of Dr. Quiñones, and I was very excited to read it. And it was my fortune that some months ago, actually 3 months ago, I was able to get it signed by Dr. Quiñones on February 2015. And since that time, I have a big inspiration and motivation to be a neurosurgeon. So it helps me a lot, for sure. I also want to thank different institutions in Guadalajara, in my university, the neuroscience department of the University of Guadalajara, Professor Rodrigo Ramos, that was the one that led us to do an ANTS student chapter, and later on also a Mission Brain, and has been the sponsor of this student chapter since a long time ago, and has a big connection with Mission Brain. During this time when I was a student, I was part of these programs. I was affiliated, then secretary, vice president, president, and also resident advisor. So it has been a huge impact for me, Mission Brain, and of course also ANTS student chapter. Also, we were to a congress since we were students, and it was on 2024 that I get the Mission Brain and Juan Beckman Vidal Fonet scholarship. I want to thank, of course, Mission Brain and all the part of the team for this huge opportunity that really supports me in those 6 months that I spent in the United States. It was an excellent experience that I will share to you some of that. But I want to thank publicly about this. And the scholarship was to go to these two hospitals, the St. Vincent and the Arkansas Neuroscience Institute under Professor Eli Christ, and the Stanford Hospital with Dr. Juan Fernandez Miranda, all around school-based and vascular neurosurgery and complex tumors. That was the part that I was most I was most interested and passionate about that. So why I select to go there? Well, I have heard of this doctors for a long time. There were really masters, black belts in the area of neurosurgery. Dr. Chris really master in the open neurosurgery, and Dr. Juan Fernandez Miranda, most recognized for endoscopic. He's also a great neurosurgeon, open neurosurgeon, but he's most famous because of the endoscopic. So they are really good neurosurgeons. They are famous neurosurgeons, but they are supported by data. They are supported by papers of huge impact in the whole area of neurosurgery. That is why I decided to go with them. And I really was not disappointed. I was really amazed by all what I see during those 6 months that I will share now to you. So Dr. Chris is a master in the cavernous sinus from the lateral perspective, the school-based approaches, the vascular aneurysm surgery, and Dr. Fernandez Miranda is more into pituitary adenomas, medial cavernous sinus, and complex endoscopic lesions. So the first was in the Arkansas Neuroscience Institute. I was there for 6 months. This is a video that I taken, so you can see how is the Kansas Neuroscience Institute from outside to inside. And I don't know if there is other surgeon that operates that much, that he opens, Dr. Krish operates 3 surgeries on average per day from Monday to Tuesday. He starts and he finish till closing the dura. So he really operates a lot. So he tells us all the time, it is very important to see a good surgeon operates. And I think this is a very good place to see a lot of surgeries doing completely by a single surgeon. He starts, he opens the skin. You can see all the steps from the beginning. You can ask all what you want. You can be really close to him. So a lot of the part was to see him operate, to be in the OR with him, and to be able to discuss the cases. I think that to learn, you really need to analyze each step and see and ask why this step, why I need to do this. So you can ask and make your conclusions, and then you can apply them. I think that's the process. So we see a lot of surgeries. I have data of all of the surgeries that I saw there. So they will help me from now on. Also, we did presentations to Dr. Krish when we discuss articles. We do a lot of cadaver dissections. When we were not on the OR, we were making dissections of the whole head, from the neck to hold the brain. We can do all what we want to the specimens, and we have a lot of time, so we were able to do it really calm and understanding each step. I actually also have a data of all of my dissections that I did there, so that knowledge will be with me all the time. So this is a dissection of the neck. We can see the carotid, the bifurcation, the nerves around the hypoglossal nerve, digastric muscle, the occipital and sternocleidomastoid artery, the jugular vein. And I will show you, because all these will be needed in a moment. So I was very happy during those 6 months. I learned a lot. This is one of the biggest laboratories. They have a lot of microscope, and these two rounds of microscope, and a lot of stations. So we always have one station for us to work, and we have a head. We can do a lot of approaches. As you can see here, these are just some of the dissections that I did there. For example, this, of course, a translabyrinthine approach. We did make the retrolabyrinthine, preserving the semicircular conducts. Then we open it to be able to understand it. And then we also remove this to do a complete translabyrinthine approach. This dissection also of the carotid artery. I dissect a lot of carotids, a lot of necks. So I wanted to understand this area, because it was in that moment a little not clear to me. These are some of the surgeries that we saw, the brains that we could dissected, surgeries. Dr. Krish also draw. We have on Wednesday, the days that we don't have surgeries, it was day of consultation. So we were with him, and he tried to explain us every case that he saw, also draw for us the anatomy, to how he understand it in his mind. And he several times was with us in the laboratory, teaching us, telling us what's the next step, what are we seeing, how he does it, so we could reply it on the specimen. Here another aneurysm, and oh, let me see. Yes, here another aneurysm and brain dissections. In this specimen, for example, the one in the middle, I preserve all the border of the insula, but I dissect in the middle and then try to study the lenticulostrate arteries, how they come. You can see the artery here and the middle cerebral artery, and I was analyzing all the distribution of the lenticulostrate arteries, where they come from and what is the normal direction that it goes. So I can apply it later. And I did a lot of white matter fiber dissections on the very good preparated brains. This is an example on a specimen, and I was taking normal photos, but also 3D pictures with glasses with red and blue. You can see this in 3D, and I did it, and it was very, very nice. We are working on a paper to publish also some of these images, so it can be available. Because it is a very easy way, I think, for the people to see the anatomy, but not in 2D, to see it on 3D. And it is really, I was really amazed with the results because it was very clear to see the brain and understand it better. So I will show other dissections. This is like the brain that I was working with. Really nice, preserve a lot of time in formal and then iced to be a really good specimen. I was able to dissect all the superior longitudinal fascicle to see all the tracts, the fronto-occipital fascicle, to see the uncinate fascicle, and to see also here I was dissecting. You can see the claustrum. This is the claustrum, and I make this nice like a straight dissection of the claustrocortical fibers, so it was clear to see it. And below is the putamen, and also a medial dissection, the cingulate fascicle, the corpus callosum, and I was dissecting here part of the circuit of Papez, that is the mammillothalamic tract of big Dacier. Here, just dissecting the hypothalamus. This is the mammillary body, the anterior commissure, and the fornix, pre-commissural, post-commissural, and understanding really all this anatomy, the middle straight, and also doing black and white pictures. This is actually the red nucleus. It is better see on this image, mesencephalon. So red nucleus, and right above the red nucleus, hypothalamus, thalamus, pulvinar. So really to see this on a 3D perspective of all the views really helps a lot to understand all this anatomy, very complex anatomy. Again, neck dissection. I did a lot of neck dissection to understand complex skull-base tumors from the mastoid, following the jugular vein, actually trying to simulate a glomus surgery, preserving the anterior wall of the jugular vein, and dissecting all the nerves, preserving this nerve. This is the accessory nerve. This is the sternocleidomastoid muscle. And the veins, the arteries, try to understand really complete the anatomy and following each step. Again, the approach for endarterectomy and complex skull-base tumor. So we were able to fuse the approaches and then understand how the nerves goes in its complete pathway. So during this time, the acquired abilities were for sure cavernous sinus surgery from the lateral perspective, how to master it, how all the tricks, how to be able to resect or even clip aneurysm in this area, or how to resect meningiomas, schwannomas, or use it as an approach for the posterior fossa, like basilar aneurysms. Brain aneurysm management, surgery and management, when to operate, when not to operate, and all the correct approaches and techniques for doing the clipping. Low and high-grade glioma surgery, complex meningioma, a lot of complex meningiomas, and carotid endarterectomy. It was curious to me that when I was going there, I didn't knew that Dr. Krish performed a lot of carotid endarterectomies, and seeing him doing it all time, have each step systematized to do it very quickly and with very good results, also inspires me to learn about the carotid endarterectomy. Epilepsy surgery, even AVMs, cavernomas, Chiari malformation, and vestibular schwannomas are just some of the things that we learned there. For sure, more than that. So I want to show you a case. This is one case of endarterectomy that I did on June 2025. So almost 1 year after I was with Dr. Chris. This is a very good book about all the occlusive cerebrovascular disease. So it was done on June 2025. This is a 77-year-old male, originally from Palo Alto, California, very close to my city in Guadalajara. We have a town called Ajijic that a lot of Canadians and United States people come here to retire. So we have a lot of North American medical tourists even. So he presented with acute confusional state without focalization. He was done first a CT scan that was normal, and then we performed the MRI. And he was presenting with left hemisphere 24 infarctions. And when we do the workup, he was with 85% left carotid stenosis. So I will show you a video, but these were just some. He had this type of 24 infarctions all around of the left hemisphere, even some on the right, and he was with 85 carotid stenosis on the left side. So you can see, I will show you the video. He presented with several 24 infarctions. It was to me like low flow, like no embolism. I was thinking more in insufficient flow to the brain. So I think that the endarterectomy to me will also help to improve the flow to the brain. So let me change here. So we will see the video. So he was with 85 on the left side and 45 in the right side. This was the reconstruction. It was a really, I think, high bifurcation. It was at C3, but the plaque was going to the junction of C2 and C3. So it was calcified. So I was expecting it not to be that easy. And that is the reason why I decided to do this type of incision, going from the anterior border of the sternocleidomastoid muscle and then turning posteriorly, so I could move more the muscle to posterior and be able to see high enough. So I did commit one error in the surgery, that was not to ask the staff to put in high quality the video. It was recorded in low quality. Sorry for that, but we'll see now the surgery. So we did this Rommel tourniquet. We are seeing here the digastric muscle and the hypoglossal nerve. We close the artery in the I sequence, actually completely following the steps of Professor Christ. Opening the artery with these spot scissors. For this type of surgery, it is really, really helpful. It is really not helpful. We must have a very good trained staff. We must have 6 hands. We have a surgeon in front of us that must be really trained in this type of surgeries, and another one that is irrigating, and both of them must be really trained, so we does not lost any minute. Because as I learned it with Professor Chris, was not usually using shunts. It was just doing one step after the other, not stops, with a good team, with another cerebrovascular surgeon in front of me that is helping me, and doing this contraction to finally dissect the plaque. Then we start to clean the artery, not to leave any remnants that could embolize. Continuous irrigation to keep it clean, nice. And then we do this tack-up suture for the distal plaque, and we start to close. Now we are starting the flow, letting the internal carotid to reflux a little bit to get out the air and some detritus. This is the ansa cervicalis that we're retracting here. Then we inject the solution with heparin inside of the artery, and then we restart the flow. This is the plaque that we remove and the status of the patient after the surgery. And we can see here, now we have 8 months of follow-up. This is the plaque. This is the patient after the surgery. He presented with no deficit, right hand good. He was speaking, right leg also good, no problem. And after 2 months, we performed an CT angio to see how the artery was. And you can see how clean it is with no stenosis and really good flow, no strokes in this period. Now, I was 3 months at the Arkansas Neuroscience Institute. Then I went 1 month to Stanford, and then I came back to Arkansas 2 more months. So I was then making a stop and going to see other surgeon or working team at the Stanford Hospital. It was also very, very nice. It changed my perspective. All of this training has changed every step my perspective. So I was in the OR in this beautiful hospital, seeing a lot of technology, virtual reality, navigation, a lot of the best equipment, and learning directly from Dr. Miranda. Reading, during that time, I really get under learning all of the steps. I read during that time all of the articles of Professor Miranda, and to understand how he actually removed the middle wall of the cavernous sinus that is presented in this image. And these are some of the dissections that a friend of mine, Joaquin Chuang, performed on the Arkansas Neuroscience, on the Stanford Neurotrain Center. He sent to me, he allowed me to share. Actually, during that time, I learned that they do the endonasal dissection like this one. They usually does not use the endoscope. They slice the head and use a microscope to take this, to do these dissections. So I get the idea to do it later on the Arkansas, a similar approach to study this anatomy. And this is what I did when I came back to the Arkansas Neuroscience Institute. I start to study the same view, but with a microscope, to understand the anatomy and to see all the ligaments, all the carotid relationships, the hypophyseal arteries, the how to approach the sella, the tuberculum area, the clivus, and whole this anatomy, and to how to do the approaches. So what was the acquired abilities here? For sure, a lot of adenomas, pituitary adenomas, complex ones that are adhered to the medial wall, functionate adenomas, Cushing, acromegaly, prolactinomas that need surgery, chondrochordomas, craniopharyngiomas, ENT approaches, and the cavernous sinus surgery from the medial perspective. So I was able to see how the ENT team works, and I was really paying attention also to all the approaches and how they close, how they put the flap, the non-septal flap. The ENT, really, I learned a lot from them. That is the reason why I want to thank also the team, not just Professor Fernandez Miranda, but also the team of ENT, Dr. Wang, Dr. Patel, Dr. Chang. I was really close to them. I could ask all what I want to them, and they were very accessible to let me know all of his secrets. So I will present another case that I did on July 2025. This is a 50-year-old male, several visual disturbances, as you can see. He has classic bilateral hemianopsia, and he has hypocortisolism. He has this big pituitary adenoma, and he was not being helped here in his hospital was not helping him. He was in a waiting list for 1 year, so we tried to help him, try to restore some of his vision. And this is the surgery. So when I studied the case, I thought that it was a very fragile diaphragm, so it was a risk of pituitary of CSF leak. So I did an septal flap from the beginning. And this drilling with irrigation is really important, and not to bite with the Kerrison when we are opening the cella using the Kerrison. Hemostasia, opening the dura with this also retrograde knife that Professor Miranda used. A little bit of the bulking. And then after the bulking, I will start doing a pseudocapsular dissection. So in these big tumors, the pseudocapsular dissection is not of, you can see the plane here, is not for getting out all the adenoma in one piece, but to do a dissection with this cottonoid, I am separating the tumor from the gland. Doing more, and you will see there is a plane there. That's the gland in the left side that is really compressed, and in the middle is the pituitary adenoma. Actually, the plane is really nice seen here. I am doing a round dissection with the aspirator here to continue the plane. And doing this pseudocapsular dissection. Now, with the cottonoid, I am keeping the arachnoid in the superior part, taking care not to open it because I don't want the CSF leak, and preserving the cottonoid there, doing like microsurgery technique with the endoscope. Doing dissection and then pulling a little bit with caution, okay? And you will see here now why I am keeping the arachnoid, because it will really prolapse a lot. You see, it was really prolapsed. So I need to put some fat there, put a bone buttress. I usually don't use the bone buttress, but I need to put it to keep the arachnoid there, and put the non-septal flap. I have it, and the arachnoid was very thin. Even I didn't have a CSF leak transoperatively. I prefer to put the flap in this case. Okay, so, and this is the result. This is the result: complete resection of the adenoma, preservation of the gland that was compressed. And actually the patients, when we do an appropriate dissections, the diabetes insipidus is rare. The patient actually present with a CHAT. This patient present with a CHAT. He was then presenting 1 week afterwards with low sodium, like 119, and we need to go to he was going to the emergency just to regulate it, but he was fine after that, no problem. And all the preservation, it was transitory, all the preservation of the pituitary function and resolution of the hypocortisolism and visual improvement. So we are pending to do a campimetry to have the follow-up of the campimetry, but really good result. And there is one thing that I cannot mention, And it's the relation, the learning, not just from the professor, but for the other people around the world. I was in these 6 months able to talk and to be related to people all around the world, from India, Sweden, Uruguay, China, Italy, a lot of countries, Peru, around the world, and it really changed my perspective of neurosurgery and the perspective of life. So this is of great value. Also in Stanford, I was passing time with people from Spain, Czech Republic, India, China, even my host Lee from the United States that let me be in her home for 1 month. Really nice girl. And learning a lot from people around the world has changed my perspective. So this was during 2025 that I did these surgeries, and then I needed to wait 1 year from October 2024 to October 2025 to go to Japan, to Sapporo, to learn from Professor Rokuya Tanikawa. For sure, also the Juan Beckman Vidal Scholarship helped me to go there, to boost my capacities to go there. I applied for that 2.5 years before. Actually, I applied in 2023 for this spot, and they tell me, okay, you can come, you're accepted, but you need to wait 2.5 years. So that was October 2025, and I didn't want to miss this opportunity to be in this very nice country, very nice hospital, and very nice city. So we moved from Mexico to Tokyo and then to Sapporo, a beautiful city, very famous because of the snow, because of the beer. And it was a very nice time that I spent during these last 5 months. I have just came to Mexico in February 2026. And I was going there because I want to learn from this neurosurgeon, Rokuya Tanikawa sensei, really also black belt neurosurgeon, very famous around the world. It's a very nice course that he does usually on August, and a master of vascular neurosurgery, of bypass, and how to handle really the veins and the arteries of the brain. So I was going there to learn this, and that's what I get. I really get to know how, again, changing my perspective a little bit. I was learning this with Professor Christ, but again, reinforcing this knowledge, how to clip this aneurysm. These mini clips were developed actually by Dr. Tanikawa. So I was with the guy that developed this clip. So also learning microsutures. These are bypass, but they apply the microsutures to whole approach to all the surgeries. They suture the vein if they bled. They suture in the trigeminal neuralgia, as I will show you. They suture every in the aneurysm. They reinforce the neck of the aneurysm with sutures. So I really learned a lot there. High technology, of course, ICG. The image was uncompared to other hospitals, really nice image, preoperative images. And we train with this, with synthetic, very small blood vessels in the same OR that during the day we do the surgery. During the night, we train the same microsutures. So what was the acquired abilities here? I learned several aneurysms. We need to draw before the surgery and after the surgery, all the anatomy, all the veins. You can see here really nice studies, imaging studies, to see if veins are surrounding the aneurysms, all the relationship of the aneurysms, to understand and go with a winning plan. The stroke, neurosurgeons in Japan, in this Teishinkai hospital, they manage each stroke. All the patients with stroke go with them, and they decide if they require any approach, endovascular or opening, thrombectomy or bypass for omitting the flow, or other approaches. They decide what to do with the stroke. So it changed also my perspective that we need to be more involved in strokes. Moya Moya, I learned from Moya Moya, carotid endarterectomy again, brain bypasses, surgery of complex skull-based tumors, and trigeminal neuralgia, as I will show you. So again, sharing a lot of time with very nice people from Egypt, from Georgia, from Saudi Arabia, for sure from Japan, and looking, helping and being the first also surgeon there in the side of Professor Tanikawa, watching all his steps and how he managed the vessels. Okay, so I will show you one last case. This is a trigeminal neuralgia, and there are two ways to manage the trigeminal neuralgia with a microvascular decompression: the interposition with Teflon pledge, or the transposition, okay, to moving completely the artery to another place, so it is not touching the nerve completely. So I first learned from this technique of Dr. Sindou in a congress, but I was learning more all the steps and how to do it here with Dr. Tanikawa and Dr. Ota and all the team of the Teishinkai Hospital, because they do this in every case. So this is a patient, 69-year-old female, that present pain triggered by eating, brushing her teeth, touching its triggering points, and talking. She has trigeminal neuralgia on B2 and B3 territory, and she refrains from eating and talking. She's afraid of having a pain, so she's trying not to eat and not to talk. So it is a severe trigeminal neuralgia that is not responsive to medical treatment, a typical trigeminal neuralgia in shocks. So this surgery is recent. I did it on 1 month ago, and it was caused by a compression of ICA. The ICA artery that is here, you will see it on the video, is making a superior loop and is compressing the trigeminal nerve. I will try to show you. This is the point where it compresses the right trigeminal nerve. And you can see there. And the loop, you can see here is coming the loop and going down here. It goes up and down, compressing, and then going below the 7 and 8 complex. You will see it again. It is coming here, the ICA, then it goes up and then goes down and compress the nerve right in the root entry zone. This is a draw that I tried to schematize what was the currents of the ICA, with the path that it goes, and to just take in mind how I will manage. I was doing this type of incision. Why? Because I want to take pericranium to do the sling to move the artery, and I use a technique that I learned from Dr. Morcos, Jacques Morcos, that is to plan the incision. I mean, from the external auditory canal, I draw a line to the inion, and then 4 centimeters in female, around 4 centimeters, 4.5 centimeters in men. That's the point where our burr hole must be, to be in the junction of the transverse and sigmoid sinus. So I draw this point. I also draw my expected craniotomy, and then with this, the incision. There are several types of incision for retrosigmoid approaches, but this is the one that I like. This is the approach. You can see I am using a Leila retractor as Dr. Christ. I mark my craniotomy as I learned in Teishinkai, and I preserve this pericranium, this aponeurotic fronto-occipital aponeurosis, to take my sling to the transposition, but also to have a point to suture my muscles at the end. Leila retractor. And opening the dura, then I will do the drainage of the cisterna magna cistern for the cerebellum to relax and not to retract cerebellum too much, retracting the dura. And then I will start first to dissect the petrous vein, superior petrous vein, and the horizontal fissure of the cerebellum. Why? Because it will allow to move the vein without needing to coagulate any vein, as I learned with Dr. Tanikawa and Dr. Ota. So I will take my time to dissect all this arachnoid and really to free all the veins and all the arteries, okay? You see, the patient has a prominent supraarcuate prominence. Yes. So it is really prominent. So I need to dissect more to have space. So now I am releasing free all the vein. So more superiorly. This is the arcuate artery that we can coagulate, no problem with this, coagulating this. So to release the ICA, this is actually the ICA artery that comes inferior and going posterior of the 7-8 complex that is here. So arcuate artery that we coagulate and cut here. Then releasing more the arachnoid. And we now see here the trigeminal and the compression of the ICA artery that goes up and then goes below. This is the ICA artery, but seeing posterior to the 7 and 8 complex. So I must release more of this arachnoid to be able to get to my interest area. You can see here, releasing more the arachnoid. This is the labyrinthine artery, the one that we saw a second ago. This is the labyrinthine artery. I will show you again. The labyrinthine artery. So it is displaced superiorly and anteriorly. Usually it is close to the 7-8, but because of this loop, it is displaced superior and laterally. I am moving this here, the artery, that is it is really redundant superiorly. So now I am taking the sling, the pericranium sling, to do the transposition. First, I was trying to retract it superiorly in that area, but then I saw that it was not okay because I was retracting the labyrinthine artery, and actually I was doing like a loophole around the 7 and 8. So I didn't like that, and also it was not releasing the compression completely. It was just moving it a little bit. So then I say, okay, what if I just move it here below the 7 and 8? I think I can suture here. The labyrinthine artery will be in a more anatomical position, and I will release all the compression and not surround the 7 and 8. So I think, okay, I think this is better. I was dissecting more the arachnoid, releasing free the 7 and 8. So the ICA, and I am pulling here the artery. I will show you in a moment. I take out my sling and I will show you here. I am pulling, you see? Now the artery is not compressing the ICA. I just need to change the loop that was there to a loop that is posterior to the 7-8 complex. I put my sling, pericranial sling here, the expected point where I'm going to suture, and I simulate here. You see? I am simulating the I am suture here and how it moves. So then I suture to the dura with 7-0 proline. Suture there and making sure at the first notch that it is not touching. So now it has a gap between the trigeminal nerve and the artery. And we proceed to suture in this anatomical position. Okay. And now, final confirmation, no touching, no risk of relapse in that area. So I am very happy with the result at this point by the decompression. You can see, very nice. We have a very good gap here. And the patient present completely resolution of the symptoms after surgery. It has not came again this pain. And she just presented with some nausea and even vomiting the first day after surgery. But after that, she is completely fine. And what is the future of neurosurgery? I think that the future is really exciting for all of us. The neuroimaging is really getting ahead. The surgery of glioblastoma, Dr. Quiñones have worked, and Mission Brain have worked a lot about that. And even in spine surgery, navigation, robots for spine, even robots for endonasal endoscopic surgery are now being developed in Japan. So this is a robot to do the movement, and the surgeon is here. So they are developing this. We have robots now that do the stereotactic surgery almost alone. So they are very precise. Navigation, as we use here to drain an abscess, also really precise, and endovascular is really taking ahead also. So Neuralink, just to mention. So after I came to Mexico, after being in the United States, I made a team with a pediatric neurologist and adult neurologist, so we can handle these pathologies together and really offer the patient the best. These are doctors that have been my inspiration for a long time, and these are phrases that I've taken from Dr. Juha Herniemi, that was one of my first also heroes. Medicine is a lifelong study, and anatomy even more. We need to steal surgical experience. Go to good surgeons to see how has been his success and their errors, and to not repeat these errors and learn from them. Ask them all of the questions that we have. Spending time in the cold corners of operating rooms around the world, observing the best neurosurgeons. So you're welcome. If I can help Mission Brain with anything, please tell me. And this is my city, Guadalajara, and I hope that we can work together for a long time.
Thank you so much, Dr. Garcia, for the very insightful talk on all of your experiences training under various neurosurgeons and then also going back to continue your practice. Before I kind of ask any questions or wanted to just open up to the audience over here, anyone wanted to make any comments or ask any questions to Dr. Garcia? This is a wonderful opportunity to learn from someone who's had such a varied experience. Oh, Paola has raised a hand. Would you like to unmute yourself, Paola?
Yes, of course. Hi, Luis Adrian. Thank you very much for your talk. It's very insightful, wonderful cases, very complex cases. So I just wanted to say congratulations for taking full advantage of this scholarship. At Mission Brain, we're very excited for you and to see you, like how you continue to bring all these things back to Mexico, because that's the idea of this scholarship. These are very, very complex cases, and where you need a multidisciplinary team. So my question is, how do you think you can now bring that back to Mexico, or what are the different like little details or things that you learned at other places that you think you can really pioneer in our country? Again, thank you very much.
Okay, nice to hear from you, Paola. You have been also from the beginning of the scholarship of support during this process. So nice to see you and to hear from you. And that's right. You know, one of the things that I learned there in the United States and Japan is that Mexico has a very complex medicine system, very complex, very fragmented. It is very difficult to transpolate the social security of all in countries to our countries. So it is I have worked on that for a long time, how to solve this. First, for sure, we need to make bridges with other specialties. Like I have a very good anesthetic team, a very good neurologist team, endocrinologic, pediatric endocrinologic, and adult endocrinologic team. And team with other neurosurgeons that must be with very good experience to solve this. But for first the team, but we need to try to help the whole social structs of Mexico. That Mexico is a very has a lot of social structs levels. So we need to make a combination, a strategy, so we can help all of them, and this is one of the things that I am working on. I have some ideas to solve this problem. I am working with some foundations, and such civil associations to improve this and to get more support and to do these surgeries, but in a high level. So I commit to do this in a high level. As I saw there, I don't want to do surgeries that are not the best for the patients. I want to do it as appropriate as then must be. For that, we need some resources, but I am working on that. I am making bridges. I am also working some articles because we need to be supported by scientific data. But I am very excited of that question because it's the one of the things that I am working on.
That's great, and that's very exciting to hear. If I may say, for my experience and the mentors that I've had from Mexico, Mexican neurosurgeons are superb. Like, they're super good, but unfortunately, sometimes the environment is not as permissive. And that's why we opened up this scholarship to have like superb neurosurgeons like you going to other places so that you can help us then bridge that back to our country. And please do let us know if you need more, like some help with some of these initiatives, with the papers. Mission Brain is always happy and excited to help people like you. So congratulations again. Thank you for your lecture.
Thank you so much. I am very happy to hear that. I will need support. So I will
Perfecto. You can count on us. Thank you,
you.
Luis Adrian.
Thank you.
Thanks, Dr. Garcia. We've got another question from Dr. Nazira. Dr. Nazira, would you want to unmute and ask your question, please? Or I can ask it on your behalf. So, they wanted to ask more about moyamoya disease and how often you've encountered it in your practice, especially in adults.
Okay, good question. So, I suspect that it is underdiagnosed here in Mexico. I suspect because you know what, the majority of the strokes are not studied here in Mexico. We are really stopping at the first step. We are not doing the CT angios appropriately, or the angiographies, or the perfusion tests. We are not analyzing the carotids. In general, Mexico. So a lot of patients with strokes just had the stroke and that's it. So we need to diffuse to communicate this information, so the whole diagnostic approach be done, so we can diagnostic more and help those patients before they have a major stroke. It is rare to see it in Mexico. I have seen maybe 2 or 3 cases, but it is rare. Maybe more, maybe like 5, but in Japan, for sure, I saw more. That's the place where I learned about this and study about this and learn from Dr. Ota and Tanikawa about how to manage these cases. But that's the answer, yes.
Right. Thank you so much, Dr. Garcia. In view of time, now that we're sort of at the 1 hour mark, we'll probably take this time to wrap up the discussion here. And thank you so much for your time. And we're glad that you're part of the Mission Brain family, and we're glad that you're able to have you've had such amazing experiences, and you've now been able to go back and kind of, with your various experiences and improve the practice. But yeah, really excited for the journey ahead and to hear more from you. Thank you so much. And thank you to the audience for joining.
Gracias, Dr. Garcia. Thank you, everybody, for joining.
Thank you, everyone.
No,
Have a nice evening.
un gusto. Que estén bien, un gusto. Cuando quieran.
Thank you.
Que
Bye,
estén
everybody.
bien.
Yeah, okay.
Bye.
Le mandaremos correo más adelante para hacerle una invitación a otros programas de Mission Brain y a nuestra gala a finales de año.
Ah, muchas gracias, con gusto. Claro que sí.
Excelente, gracias, doctor. Que tenga excelente
Que
día.
estén bien.
Bye. Thank you,
Luego.
everybody, for joining. Take care.
Gracias.